topic on cervical epidurals and the root blocks. But nowadays, went to more complications on particularly the root blocks and the transforaminals. The global shift has been there towards the cervical epidural only. And very few people, even I have personal communication with Gabor Rax, he has also stopped doing these transforaminal root blocks because there are many segmental arteries and which are going through the intervertebral foramen, and there are many complications and injuries nowadays. So I will try to limit my discussion on cervical epidural injection only. Now, going for to we know that some special features will only talk. One thing is to be remembered in the posterior part in the cervical spine, sometimes there is no ligamentum flavum. So, practically a midline epidural is not to be done because often the first loss of resistance we get after piercing the dura and after going into the interthecal space. So that is one important thing. We know the boundary. I'm not going details into it. Behind is the ligamentum flavum, and in front is the dura. And this is the cervical epidural, and the posteriorly and anteriorly is the anterior longitudinal ligament is anteriorly. Laterally, the vertebral pedicles and the joint capsule and the intervertebral foramen. What I talked earlier also, that the ligamentum flavum in the cervical region is relatively thin, inconsistent, sometimes deficient, and it has got contents of fat, veins, and arteries. Another important thing is to consider the distance between the ligamentum flavum and the dura is at the level of the C7 and T1 is 1.5 to 2 mm only. So, in the erect posture, there is only hardly a space to put a needle inside it. But if the patient, the neck is flexed, then this distance increased. So, better to avoid cervical epidural in sitting position. And the indications are cervical radicular pain syndromes, disc herniations, traumas, spinal stenosis, herpes, and post-herpetic neuralgia. But we have to remember that only if there is no motor weakness, there is the effect of the pressure, motor weakness or sensory loss, and only in the pain due to inflammations, we have to see those cases only. And another thing is that in the acute phase only, it acts better. And a limitation is that it has a short lasting, it is not a long duration like that. It may last for maybe a few months or not, or like that. Some anesthetists have started anesthesia, but it has been criticized. Anyway, contraindication is a pre-cervical spine injury, and because in cervical injury there is a lot of and venous pressure in. So the veins are engorged. There is injury to the veins causing to hematoma. And the spread of the drug is also very difficult in the fibrosis. And if one cannot see the fluoroscopy visualization, particularly in the lateral view, most of them collapse and other. So common case is C7 player, actually it is very difficult. So sometimes we go for swimmer's view also. The techniques that equipments are to handle, and this is the epidural needle, but at the start, so the wax skewed to needle is preferred when it is blunt tip, and so it is to be. Otherwise, the patient